This talk is near and dear to me. I care a lot about the topic of involving families in care. A lot of my unique specialty throughout 12 years in psychiatric private practice has been the care of young adults, teens as well, but a whole lot of the care of young adults. And what I've found that I think is often true with children as well is that I can't help a teenager or a young adult if I don't involve their parents in care. There's just very little I can do. I can do a little medical stabilization. I can teach a kid skills, right? But when I have situations, for example, and I'll start with talking a little bit about young adults because that's my wheelhouse. When I have a young adult who comes in and tells me today in tears, you know, Dr. Deuter, I have a secret. I dropped 2 of my classes this semester, and I failed 2 of my classes this semester, and I passed 1 class, and my parents don't know. And I've been doing this now. This is the 3rd semester in a row. I've been dropping classes, failing classes, and my parents are going to respond. And I don't know what they're going to do. I'm afraid they're going to pull me out of school. They're going to refuse to pay tuition because I'm not doing what I need to do, okay? And in a case like this, there's very little I can do to help this young lady with that behavior if I can't get her parents to make some decisions about how they'll handle these inappropriate behaviors. And so she's anxious, she has ADD, but if they don't respond in a way that's healthy, there's not a lot I can do. Well, I think that trickles all the way down into the lowest levels of the child years, right? If you have an 8-year-old who's got a behavior problem and you can't implement a behavior plan in that home, then there's not a lot you can do. Beyond that, parents do other things that I think are important that we have to train and teach them to do in mental health, and we probably don't take the time to do often enough. And so that includes things like scheduling appointments, right? Bringing kids in, making it a priority to pay for therapy, getting in to meet with the child's school counselor. I mean, they are really the ones out there dictating what's going to happen with a child's mental health care. And so we need to work better with parents. So for all those reasons, I think this is a really important topic. Okay. So let me start by just telling you who I am and making sure that, you know, if anybody has questions about that. So I, about a year ago, opened up a mental health urgent care clinic where we serve all ages, including children. We've seen children as young as 4. We've seen adults as old as 94. So thus far, that's our range. We do see a great many adolescents. A lot of people who enter into mental health assessment and care for the very first time are between the ages of 12 and 30. And that's when problems onset. That's when there's a whole lot of developmental stuff happening where it might not be a mental disorder, but there might be some kind of a crisis that looks like it could be a mental health disorder. And so in the midst of working at Sigma and running this clinic, we work with therapists and we work with prescribing professionals in a team assessment and bring people in. And one of the things that I've been an advocate for in our teams is really bringing the families in. So it's interesting because I get to watch the work of other professionals, and they're contractors. So people who work for us, they come in, they do their craft their way. But I've been fascinated at how it's not a universal practice, for example, to bring parents in on the first visit and speak with them up front. And it's not a universal practice on a second visit to bring parents in and do a little parent coaching with them before implementing the full plan of care. And this was a surprise to me. It's actually fairly rare to involve families at the level that, you know, that many of us are taught is appropriate good care. A lot of the care that's provided is focused on the specific emotional needs of the child in question, and not a whole lot on the system, even though we come to conferences like this and we talk about how important the system is. So, you know, we all know in theory, there's been research that shows if you don't work with a family, you're not going to help the kid. But if you sit down in a clinic and you look at what's actually being done, it's actually not often enough. I think the other thing that I've learned firsthand working with people is the misinterpretation of HIPAA. That people believe, particularly if you get an adolescent about age 16, a lot of our professionals will believe that they're not allowed to talk to the family, when in fact that's not true. You're not allowed to share secrets, but certainly if the mother's in the waiting room, the father's in the waiting room, it's okay to have a conversation and say, how do you think things are going? Or what would you like for me to know? Or are you concerned about safety? Or, things like that. Are there things I don't know that are going on at home? And of course, we all know, raise your hand if you're a clinician. If you are a therapist or, okay. And so those of us in clinical practice, we know that you talk to any family member, whether it's a child or adolescent or an adult, and you frequently hear back that there's a whole lot going on that you didn't know about. That could be husband, wife, parent, whatever, but you hear, oh no, she says she's doing terribly, but she looks better at home, or she says she's doing great, but she's not getting out. Child's refusing to go to school, or things like that. Okay, so I want to talk about why this topic's important and why bringing parents in is so vital. And so there are several reasons. One is that we see people, if you're an educator, if you're a clinician, you see people for a fraction of the time that they're out in the world. And so we have just a snapshot of information, and very often we have that in a context that is not their everyday context. It's limited. Somebody comes into clinic or they come into the school counselor's office, and you see them differently than they may be at home. So that's really important to remember. Hospitalized kids even go back home. Kids come to the hospital, they stay in the hospital maybe for a week, and that's 24 hours a day. But then they leave the hospital and they go back home to their parents. IOPs and PHPs, right? 6 weeks. They come in for 3 hours a day, and then they go back home. Counselors who see patients every week may meet with them for an hour a week, and that's a lot of time. But what we see in the room is very often still just a small snapshot. Prescribing professionals, even less. Is there anybody in the room who's a prescribing professional, a physician, or, okay. And so increasingly, even in mental health, visits are minutes long and months apart. So somebody comes in and they're making these really important decisions about psychiatric medication in 10 minutes once every 3 months. And so, of course, the parents then become vital as part of the system to figure out what's really going on. And so, kids spend their time where? At school and with their family. And so I think one of the things we do sometimes in ADHD better than other fields is we work with schools and we find out what's going on at school. We find out, is a child having trouble concentrating, getting work in, and things like that. But for other mental health disorders, we're not always doing that. And, bipolar spectrum disorders, autism spectrum disorders, there are a lot of things going on that are relevant in the mental health world, and we need the folks out there to come in and become better partners in the treatment of our kids and young adults and even adults. All right, so the reason it's important to educate these different people in these different roles is a couple of things, but one is that, it aids in early intervention and prevention. That makes sense. So if you invite families and you invite peripheral contacts into care, then you increase the likelihood that they're part of the process, and if something's going wrong, then the team will be alerted to that early, and that's important. But it's also, it decreases the public health burden, and what I mean by that is if you can empower families and communities to handle things at home, you intervene early, you keep kids out of the hospital, you keep unnecessary visits from happening. So I was talking about this talk earlier and before the conference to an attendee, and the thing that came up was, well, yeah, sometimes in the severely mentally ill or disabled populations, you see kids coming into the hospital and being admitted because the parents need a break. And if you can empower the families to be partners in the mental health process better, then you decrease the risk of things like that happening. You decrease hospital days, you decrease, dollars, and I think far more importantly, and something we should all be talking about in mental health care, you increase access to care for someone else who needed that hospital bed. Because for those of us, I think in the San Antonio community, but I think this is everywhere, access to care has become impossible, right? If you need to admit somebody to the hospital, it's not uncommon to not be able to find a bed. If you need to find somebody outpatient care, it's not uncommon to have a lot of trouble finding an outpatient professional who can see somebody, adult or child, for months. And so, for example, at Sigma, where we see people for short-term care, we'll have people call us and say, I have called every name on my insurance list, and I either can't get a call back or they say it's going to be 4 months to get an appointment, and I'm in a crisis and I can't wait 4 months. And so when we take people out of the system by making sure they have the support they need at home and by triaging problems better, we open up that space for someone else who needs it. Okay. And so, we need our families to be our eyes and ears. We need our teachers to be our eyes and ears. And there's a whole nother layer there where we have to have consent and we have to have a better partnership with schools. But with parents, certainly they are involved. And I think that we as mental health professionals have to do a better job of accepting that they are our partners and that we need them to be part of the process. And like I said before, they control access to care. And so if the treatment providers for a kid don't have a great relationship with the parents may not schedule appointments. They may not bring kids. They may let things sort of fall off. And that happens, I think, far too often. I've seen a number of cases, particularly with adolescents, where a child will come in to see me, maybe 12 to 16 range, and the parents will come in and say, we were seeing a professional, and we stopped going because the individual we were seeing did not speak with us, and we had no idea what was going on in the room. And after 3 months, we didn't see any progress, so we quit going. And that's a pretty common problem. Okay? And then, so I think one of the things I want to emphasize is that we in the field are the ones who define their job description as our partners, and we haven't done a very good job. We really need to say to families, here's what I need you to do in the home and between appointments. Here's your role. And I think there are a lot of reasons we're not doing that. One of them is time. And then part of it, I think, another problem is the misidentification of our role. So if we come in and we say, my problem is to help a child, we don't necessarily bear in mind that in order to help the child, part of our role is to help the whole system, and we have to be attentive to doing that. We can't just relinquish part of that role because it's not the fun part. Of course, being with the kids is more fun and what we all train to do, okay? And so, when I meet, when I meet with an adolescent, I very often have a procedure that goes like this, and I think that this is what we're advised to do. I'm not sure we all do it. But what I do is I bring in the kid on the first visit to do the assessment, and the first thing I do is bring kid and parents in together in front of kid and say, can you help me understand why you brought your child here today and what your goals are and what the problems are? And so I let them talk, usually until it feels tense or it's a little too much. And then I stop and I say, let me ask you a few questions that probably only a parent can answer. Can you go back and give me some developmental history? Did your child walk and talk on time and read and all those kinds of things? And then I ask, are you worried about safety? Are you worried about risk-taking? Are you worried about drugs and alcohol? Are you worried about things like that kids are not going to tell me, right? Because kids will talk about how they feel. They'll talk about, I feel sad, I feel nervous a lot, but they won't necessarily say, I break the rules and I put myself at risk, so I'm going to need the parents to tell me that. And I usually ask those questions in front of the kid so that we put it on the table, and then I excuse the parent, interview the kid, and say, what do you think about those things that your mom and dad said? They said that you were taking a lot of risk. Let's talk about, how you feel about that. And again, it's sort of on the table. And then the next thing that I do after the assessment is I usually schedule a second session with parents only without the kid. And I think this is another thing that again, we're told to do, we often don't do throughout the mental health care profession. And the reason we don't do it is we don't have time, and we don't want to violate the trust of the patient. So what I usually do with the adolescent, if it's teenager, is I say, I want to meet with your parents, and I want to do that before I know you very well. So I'd like to do that the very next session, hear more from them, talk to them about what their role is, talk to them about how they can help, and then I want to see you and get to know you better, right? Because we've kind of skimmed the surface on the first visit. And so in that parent visit, I usually talk about things like the structure in the home. Do you have rules? Do you have chores? What happens if you break a rule? I encourage families, again, at all ages, to have a list of house rules, write them down, post them on the wall, try to make sure kids understand what they are, and talk about them. Things like, we treat each other with respect in this family. So it wasn't respectful when, you hit your sister and sat on her head. It happens in my house a lot. There's a lot of sitting on people's heads. And so, that's respect is a rule, that we treat each other with respect. So there's a way to kind of open up conversations. And the part of the reason I think that that's a really helpful thing to do with parents is that there's something in pediatrics, there's a term called anticipatory guidance. Has anybody heard that term, anticipatory guidance? So anticipatory guidance means talking to the parents about what comes next and making sure they're prepared with a plan, right? So for example, your child is 6 months old, she's beginning to crawl, pretty soon she's gonna be mobile, and you're gonna need to make sure that the environment in your house is safe. So be attentive to that now, because before you know it, she's gonna be up and moving, and you wanna be prepared, right? That's anticipatory guidance. We're not doing enough of that in mental health care. So we really need to think about trying to have a program where we talk about, your child is 11, pretty soon you're gonna be looking at the changes associated with puberty, right? So right now you're dealing with anxiety. What's gonna happen when puberty onsets? You're gonna have more moodiness, and you're gonna be looking at some different kinds of rules. Let's talk about the use of technology. Let's talk about the cell phone, things like that, right?